Welcome everyone to our first roundtable here at the German-Israeli Health Forum for Artificial Intelligence. It's my pleasure welcoming you all. I'm delighted to welcome in particular our speakers today. I'll introduce them one after another when it's their turn for their session. But let me just very briefly introduce you to, for those of you who are with us for the very first time, to the German-Israeli Health Forum for Artificial Intelligence, or short GIHF-AI, which is hosted by ELNET, and we are delighted about the support by the Federal Ministry of Health of Germany. ELNET, since 2007, is actually building bridges between Germany and Israel and has one dedicated pillar on innovation. And that brought us together already a while ago with the German Ministry of Health, with whom we developed this program, which is actually designed to connect experts from politics, from academia, from the industry, obviously also physicians from the medical sector, to discuss pain points and potential solutions in the area of applied artificial intelligence in health. And by doing that, we focus on three work streams, which is communications and trust, which is technology and security, and which is regulation. And today we start with the first pillar, technology and security. This work stream actually will lead us over this 3-year program. And you've hopefully all seen on our website that we already published a brief policy paper on the issue. That by today, we would like to speak about interoperability of health data and corporations in science in the context of technology and security, as we believe this is the key to success. You are probably all very familiar with the progress, in particular, Germany is making in the area of digital health already for a couple of years. And you may know the study from the Bertelsmann Foundation from 2008 that draw a picture that is not valid, probably not valid like in full by today, but that showed that while Germany in those days, 2018, was still, well, let's say not in the lead when it came to digitalization and in particular to artificial intelligence in the health sector, Israel was among the 4 first countries among those who have been analyzed from the European Union and the OECD. So the basic idea of the program was to learn from the Israeli experience, to build upon that, to build use cases for Germany in order to improve and further our healthcare system with the application of artificial intelligence. And over time, we found that also Israel wants and can learn from Germany. So we perceive this health forum as indeed beneficial for both countries. And having said that, we are delighted to have so many experts now already with us on our board of trustees on the one hand, and also in our different and various working groups. So whenever you have an idea, input for our program, please feel free to reach out to the whole team of GIHF-AI. We have Leah Ledwan, the program manager, with us. We have Jakubina Janocek, who works for the program in our Israeli office. So please feel free to reach out to us anytime. But meanwhile, I'd suggest we give the floor to our first presenter for today. And I'm delighted to give the floor in a second to Professor Dr. Sylvia Thun, the Director of the Core Unit eHealth and Interoperability at the Charité. You probably know her here in this expert group. She's a licensed physician and a graduate engineer, has been a Charité visiting professor since 2018. And in addition, she leads the core facility Digital Medicine and Interoperability at the Berlin Institute of Health. And in October 2021, so just recently, she was appointed to the University Professorship of Digital Medicine and Interoperability at the Charité. Having said that, Professor Thun, pleasure seeing you again after our first meeting yesterday evening with the Board of Trustees. And we are indeed also delighted to have you among our Board of Trustees. And having said that, the floor is yours.
So thank you, and Carsten Owens, and it's a real pleasure for me to give you this presentation on a very important topic. This topic is about interoperability, and is interoperability the key for communication for digital medicine? And we will hear and see in the next 15 minutes why it is so important for connected data. So let's have a look at Germany first. We lately measured the digital maturity index in Germany, and you can see here some numbers of our healthcare system, and so our digital score in hospitals in Germany is an average 33 out of 100. So let's say 33%. So we had different dimensions measured with our questionnaire, which was aligned to the EMEA matrix, but it was not EMEA from HIMSS, but we had our own matrix here. So as we can see here, we see that Germany is quite good in structures and systems and privacy, security, and so on. And there's a lot of improvement in patient participation. And if you think about patients, they are the very important people in the healthcare system. So we have to improve here, and a lot of improvement should be here in the dimension information exchange as well, because information exchange depends on interoperable software solution and on man and machine who want to deal with fair data. Fair data means findable, accessible, interoperable, and reusable, for instance, for registries. So does digital medicine depend on interoperability? And for sure, we need medical communication to avoid errors and empower our patients and physicians and nurses. And we want to make research up on this data and create new innovative solutions. And we, as we have seen in the pandemic, we have to cooperate in an international community. So why do we need standardized data which is interoperable? So because right now today we are talking about AI and big data, and if you and AI and big data needs precise and good and high quality of data to ensure the validity of analysis results, and we have to have trust in the data and in the algorithms and in the software solutions. So who is responsible for standardizing data in the world or here in Germany? In Germany, we have our DIN, the German Institute of Standardization, and there's an international institute as well, the ISO. Here, the Technical Committee 215 is responsible for the medical informatics, and they built like about 300 different standards, and you can see some standard development organizations as well, like DICOM for imaging or CDISC for clinical trials, and standard development organizations which deal with terminologies. Besides that, we have global digital health partnerships under the roof of the WHO, who work together on the political level, and standards within the bioinformatics community. So what do all these organizations aim for? They want to build like an ecosystem of medical data that can flow. And first of all, and I think, or we all think, the most important use case is to have an international patient summary for cross-border healthcare solutions. And we specified this international patient summary in 2014 in Europe with a project that was called EPSOS, European Patient Smart Open Services. And there we specified this international patient summary, which is now an ISO standard and which is now built with new technologies. So let's have a look at Germany in 2022. Which kind of solutions do we have in Germany right now? We have an EHR since 1 year, which is based on a standard which is called IHE, Integrating the Healthcare Enterprise Cross-Document Sharing. So we can share documents, mainly PDFs. We have an emergency data set, which should be stored at the plastic card, the Gesundheitskarte, healthcare, the card. We have a prescription service, which is tested right now, medication record, or medication, we call it medication plan. And we can share documents, but only with in between doctors, and some policyholder data services for insurance companies. And the new innovative tools and software which is coming is the DiGA, the Digital Health Application, and the so-called MIOS, Medical Information Objects. And these DiGAs and MIOS are based, or should be based, on international standards. And beside that, we are working with our Corona One app, and I think most of our citizens do have this application on their smartphone. So in 2023, we plan to have a new architecture where we include the patient. I think this is the most important part, and we use smartphones and the so-called FHIR technology. And I will tell you something about FHIR right now, because FHIR is the goal, or the possibility to make interoperable solutions worldwide. And our government picked this standard for many use cases, not only for patient care, but also for registries and for research. And I think this is a point which is very important. So let's have a look at HL7 fast healthcare interoperability resources. You can imagine that these resources are something like bricks. It's like a library of health information, and with smart and modern web technologies. And you can see here on the right that you mostly have a practitioner, a patient, and the practitioner is performing a procedure, and you get an observation like a lab result or something back. And so these medical information objects, or these models, are always the same. And so we try to build this library for German, which is based on the international library. And this is based on the international patient summary as well. So here you can understand a little bit how FHIR works, like a huge library, and you can use all these models, or we call it resources, in different applications, like startups can use it, or we can use it in registries or in hospital information systems, and have at least some information objects that are always the same, like information about the patient, about gender, about the condition, and so on. So there are many challenges, like the identity management, but there are already some ISO standards here that we can use, like OpenID and OAuth. the accessibility. We need modern and very strict security concepts. Should be all interoperable. And that's still a problem, even if we work with international standards. These standards are sometimes different to within each country, because we have different philosophies and different healthcare systems here and different laws. So we have to localize the standard for Germany, or each country has to localize this HL7 fire standard. So beside that, we have many new laws which are very good, but different organizations who are responsible for different applications. So there's an organization which is responsible for the MIUs, another organization or different startups who work on DCAS, and we want to integrate sensor data and wearable data, images, omics data, and at least we want to work with AI algorithms. And these are not standardized right now. So these are our challenges, and how do we want to solve it? There's a new Interop Council for Digital Health in Germany since December 2021. And these are the heads. And behind this group, you find 100 experts, interoperability experts who will coordinate all the ongoing standardization efforts. So let's have a look at the research area. We have a big program going on from the Ministry of Research and Science, the Medical Informatics Initiative, where we want to work together with our 34 university hospitals. And here there are many challenges, especially for data security and privacy issues. But the most important part was that we built a so-called basic standardized data set with basic modules and extension models. And I work right now on the oncology, pathology, and molecular genetics record here in Germany, so that we have in the future standardized documents for our scientists and physicians. So here we have a huge data sharing framework where we can exchange data, but we always use federated learning methods so that the data doesn't leave the hospital. So beside that, we built 2 years ago this standardized data set for COVID-19 research. And within this data set with more than 200 items, we built one possibility for researchers in Germany and also in Europe. Here's another project which is going on right now, the Orchestra project from H2020, where we can share and analyze data, and the data that we got out of our clinical trials is standardized with FHIR data and with terminologies, which we international terminologies which we are all using. So which terminologies did we choose? So since 15 years, our DIMDI, that was our institution for from the Ministry of Health, provided us with allowing. That's a terminology from the Regenstrief Institute for observations and lab results, but the software vendors refused to work with LOINC. So we need here more regulations. And within the COVID-19 data set, GECKO, we use these LOINC terms. And now the software vendors learned a lot, and they are now able to use, or most of them are able to use the LOINC terms. And here you can see the LOINC sites. For instance, it gets an ID and a name, and that's it. Beside that, we are working with SNOMED CT. We are a member of SNOMED CT since 1 year as well. And I know that Israel joined SNOMED CT in 2012 already. And I think this is really important that you use, or we use, international terminologies. And this could be a success factor for digitalization. We should ask countries who work with SNOMED and other countries who don't have the ability to work with SNOMED, how mature their digital system is. So beside that, we worked on ISO standard, or standard family, which is called the Identification of Medicinal Products, IMP. And we tried to implement this standard here at Charité for dose forms and for units right now. And we are waiting for the BfArM to provide us the other terminologies for substances and the product identifier. There are projects going on, and private software vendors who provide us with these terms, but they all, or most of them, have their own solution. So we need these standards for pharmacovigilance, and for perhaps for the information in the EHR as well, or within the e-prescription services as well. So the last terminology, which is really important, is the International Classification of Diseases, the ICD-10 from the WHO and from the BfArM. And we are waiting right now for ICD-11, which is much better. And we will see what ICD-11 will bring us in the future. So this was my short presentation on terminologies, on standards for data exchange, and the whole big picture that we have, and the standard development organizations who are in charge of giving us fair data. And we need fair data to build good algorithms. So, and I made a little search, a Google search, and found the FIRE-IL initiative in Israel. And it says that you made a jump start to FIRE, and perhaps we can discuss this later, and how we can exchange here data between not only Germany, but Europe and other countries like Australia or Canada, who are also using the same standards. Thank you for listening.
Thank you very much, Professor Thun, for this comprehensive and nonetheless brief overview. So it shows really your expertise, and people who know you know that you just recently received the Federal Cross of Merit of the Federal Republic of Germany for your work on eHealth and medical data. And again, it's really a pleasure having you with us here for not only today, but also for the whole program over the next couple of years. So thank you very much. We're jumping to the next agenda item. As you have seen on our invitation, we have several topics that we want to touch here during our first roundtable about data access and data linkage, to discuss more data, better data, more connected data, but how? So this was the introductory remarks. And we will now have the pleasure of listening to Limor Shmerling, Magazanik, who is the managing director of the Israeli Tech Policy Institute, who also has a long track record when it comes to privacy protection. For more than a decade, she was actually with the Israel Privacy Protection Authority, and she even founded the Data Protection Forum in the Israeli Public Administration. So the first next impulse will be from her about protecting patient data, privacy, and cybersecurity in healthcare, followed by Oliver Keizers, who is the Area Vice President EMEA Central at Semperis. So pleasure having the two of you with us, and we'll start with you, Limor. So please take the floors, and the stage is yours.
Thank you, Carsten. Wonderful to be here and to meet some of you again and some of you for the first time. I would maybe start by saying that both cybersecurity and data protection, privacy protection are quite critical to any vertical that uses data for research, and especially, I think, in the health sector, it's even doubly true, since the confidentiality of patient data and the relationship between health organizations and health professionals and their patients and all of us practically is critical. This building of trust between the players in this ecosystem is critical to our ability to continue unlocking the power of data in this ecosystem. During COVID, at least in Israel, we were seeing and experiencing a very, very significant increase in cyber attacks on health organizations, on hospitals. Major hospitals in Israel went through data breaches, went through attacks that made them unable to operate for many weeks, and one even has not fully yet recovered from an attack that was quite a few months ago. So this is an issue that has gained a lot of attention here in the Israeli media. And generally speaking, privacy as a whole, I started in privacy about 15, 16 years ago. It wasn't that much of a top priority and in the public awareness as it is today. I think that the last couple of years have really brought to the surface more public awareness to issues of privacy as a rule. And these are all reasons that should motivate us, everyone in this space, to take extra special care with protecting privacy and data. I would say at the same time that I think that implementing and complying with data protection regulations in every project that you may be engaging in is a work of balance. We can never have 100% security or 100% data protection and privacy. The whole notion of using data, of researching data, of employing big data analytics, of using AI models requires that we use data, and therefore we cannot protect it perfectly. But we can employ various circles of protection in order to do that. There is a very important trade-off that we need to remember, that data utility needs to be maintained for research, and at the same time we are aiming for data security and data protection, and that is a quite delicate balance that needs to be done. I think that for me, for my part as a privacy professional, I think that the approach to implementing and complying with data regulations in this space, as in others, is using a risk-based approach. So it's a matter of assessing what types of harms could or potentially happen during a certain project or a certain collaboration over data, assessing those types of risks and harms ahead of the project, and trying to also calculate or even find some metrics to evaluate the probability of this harm actually materializing. Because when we don't want to do 100% all of the time. We want to prioritize. And I think prioritizing is key when we implement privacy protection and want to maintain data utility. So it's a matter of identifying risks, calculating the potential harm and to what extent it is significant, and what's the probability of this actually materializing, and then finding the appropriate safeguards that can help us mitigate those risks, and at the same time aiming to enjoy the benefits of data analytics. I want to share perhaps another point that I've come across in the past few years working on these issues, especially in the health sector, and that is around the notion of consent. So consent is considered by many as the primary way to be utilizing, to be processing and using personal data of individuals. Consent is usually mentioned first, and sometimes even only when we're talking about how can we allow ourselves to use personal data of patients. But in the GDPR, the European General Data Protection Regulations, who've become the golden standard in most countries, consent is not necessarily the privileged legal base for the use of data, and it's not the only one. It's just one of 6 legal bases that allow for data usage. So it is possible to use data for scientific research, for research in the public interest under national laws, and there are several derogations conditioned on safeguards for privacy protection or people's rights protection, but consent is not the essential necessity in order to conduct health data research. And this is sometimes even more confusing in the health sector because health professionals are quite accustomed to think about clinical trials and interventional studies, which employ the human body and are guarded by Helsinki ethics principles that are based on consent, and that is not, and their consent is the privileged and critical way of allowing the trial to happen. So it's important to differentiate between consent for clinical trials, consent for interventional studies, consent in the medical relationship profession, and consent for data protection, for the GDPR, for privacy, which is just one of 6 available legal bases for data processing. And I think that really opens up a host of possibilities that may help us tackle some of the friction, some of the conflicts that we find between data protection principles and the requirements and the necessities of health data research. I think that I will pause here and give the floor to my colleague Oliver, and if you wish, then happy to contribute more in the conversation ahead. Thank you.
Thank you, Limor. Well, then let me share my screen, or specifically PowerPoint, the wonders of PowerPoint. I'll take you even one step further down into the deep, dark trenches of cybersecurity. We're talking about data, we're talking about regulatory challenges, and now we're talking about where people really get their fingers dirty, so to speak. And that is identity. And I've heard the notion of identity, who does what, several times, and I've even seen it on one of the slides, EID, the electronic identity of a patient, of a healthcare professional, of anybody that is involved with data. There is one system that stores in, let's say, the majority of your IT environments. There's one system that stores those identities, and that's called Active Directory. It's an old system, and I'll get to it in a second, what it actually means, but it's something that has been about 22 years old now. Has been built, created in times when there was that belief of us within the perimeter security we're all good, we're all fine, we're all nice. And then there's the bad guys outside. And I believe we all know that those times are over. Those days are no longer true today. We have seen many cases of ransomware and even espionage attacks or other cases where attackers or malicious actors were trying and succeeding even to get into environments, into networks, and then were able to extract data or even only to manipulate data, or if they're really only criminals, to just encrypt your data and basically restrict you from working. All of this takes place at some point in time in Active Directory. And let me give you an idea of what that means. First and foremost, yes, the stakes are higher in healthcare, but you know what? You have exactly the same problem as a manufacturer, as a printer, as someone that drives trucks, or a bank, or any other high-tech company. Your IT systems rely on something that, as I just said, is 22 years old. But even more so in the healthcare industry, you have a lot of regulatory requirements, Patientendatenschutzgesetz, just naming one, or the fact that many of, especially the hospitals of today in Germany, are considered kritis. That brings a wealth of requirements. And when you look at what the Deutsche Krankenhausgesellschaft basically has put down in their standard, if you want to call it that way, B3S, that is all about business continuity. And I think we all know the very old example of Lukas Klinikum in Neuss, that took weeks, if not months, to get back alive, to get back to work. And even if you go to cases of this year, all of them originate from the same challenge. And that is the fact that you have identities in an identity store. And those identities are not only those of a doctor, but they're at the same time those of an administrator, of a highly privileged individual. So you get the entire range of capabilities within one single data store. That makes it pretty obvious that that one single data store is super interesting and super important for an attacker. But even more so, we're all talking about the cloud. Yeah, I know we don't want to put patient data in the cloud and privacy and so on. I understand that, but nevertheless, that is a fact of today. And that Active Directory, that identity store, is the source of basically all of the cloud services, at least of the identities that are being used in all of those cloud services. And subsequently, that fails, all those wonderful data stores, all of those wonderful processing capabilities, all of those wonderful applications that you're using on your smartphones or anywhere else, they will at some point in time fail as well. That gives you an idea of how important Active Directory is, despite the fact I would bet the majority of you have never heard of Active Directory before. Cybersecurity, as I said, that's where you get the fingers dirty and, well, sometimes wet also. So what is it that needs to be done? Where do you or where do your security professionals specifically need to focus on? And that's basically three things. And you can look at it by timing, by saying it's the entire time before an attack happens, which is hopefully endlessly long, but realistically always too short. Then you've got the time frame in between an attack or during an attack, basically, when you have to make sure you understand there is something going on. Most of the cases, we don't even know that there is an attack going on. And then obviously, after an attack, you have to recover. And that is a multitude of things. It's the protection, finding weak spots. And again, let me rephrase that. 22-year-old technology forms the basis of your IT systems. It is like a Swiss cheese. It has countless open holes that will allow you to, or not you, but an attacker, to actually get into those identity systems. Find those weak spots. Absolutely the most important part. Make sure you monitor, you detect any changes, you monitor all of those changes, and even be able to fix them, to undo them. And then sometimes, and we all have seen cases of ransomware or just wiperware or any other malicious activity, you have to be able to recover it, because if your identity system does not work, Nobody cares for your applications on top. It's the identity system that even the application itself identifies itself so that the application can work. No underlying identity system, no other IT is even remotely capable of working. So that's the circle, as NIST calls it, their framework. That's the circle of protect, detect, and restore that needs to be maintained, and especially maintained when it gets to the topic of Active Directory. And let me briefly talk about two of our customers that we've been working with from especially the healthcare industry. One is Prime Healthcare, a very large California, clinical chain or hospital chain, if you want to call it that way, with more than 50,000 employees. For them, an outage, again, this is one system that holds the entire identities. An outage means basta, nothing more working. They have been primarily focusing on the business continuity capabilities. So what I had as restore on the NIST framework. How can I, if we all know security is never 100%. The only security that is 100% secure is a system that you just switch off. We don't want that. We don't need that. We need our IT to work. So if you cannot prevent anything absolutely from happening, at least you need to make sure that you can have a high resilience or then subsequently a very fast getting back alive method. That is what Prime has been focusing on. There's another company, as far as I believe, also in California. They have actually been looking at the entirety. They started looking at what are my weak spots, get my IT security, get my identity security to a known secure state. They are definitely very, very well suited to make sure that those identity attacks are at least made difficult, but also they are as well focusing on the resilience part, being able to recover basically an Active Directory to a safe state. That is what we see in lots of hospitals, and especially in Germany. I'm probably I don't know. I've maybe been talking to 15 or 20 different hospitals or healthcare providers that are focusing on this, and not only due to Kritis and Patientendatenschutzgesetz, but also just for simple logical reasons. So when you think of wonderful data, wonderful regulations, also think of the underlying security, because that is everything that will enable you to use all the rest. No security, no systems.
Thank you very much. That was also very timely, actually, Mr. Keizers, for the presentation. So that leaves us already for now with actually this second slot on our agenda. We will have room for Q&A at the end of our Impulse keynotes that we're having now during this roundtable. So, but please feel free, if you already have questions for the presenting speakers or in general, use the chat box, and we'll make sure that your question will be heard, and we will have enough time later on to discuss. So, jumping to the next topic of today's first roundtable, it is about storing and using health data in Israel and Germany. And again, we have two distinguished experts with us. Dr. Yael Pomerantz holds a PhD from the Weizmann Institute and looks back at an impressive career in the healthcare sector. And now she is the business development manager at Clalit Innovation. And next to her, we have Dr. Katharina Schneider, a researcher at the Research Data Center, FDZ, or at the Federal Institute for Drugs and Medical Devices, BfArM. So again, it's a pleasure having you with us. And I'd like to give the floor first to Dr. Yael Pomerantz.
Thank you very much. Thank you for having me. Let me also share my screen real quick. Yes, so as mentioned, I'm the Business Development Manager for Clalit Innovation. Here we are. And I would like to tell you a little bit about us and about Clalit Health Services. So Clalit Innovation is the innovation arm of Clalit Health Services, and we are trying to be the bridge between this big organization that provides healthcare to people in Israel and the world of innovation, the ecosystem that consists of the startups and healthcare and tech companies, to bridge between these two worlds in order to provide better healthcare to our patients. So Clalit is one of the largest integrated healthcare providers in the world, and actually the longest running one. It's one of 4 that operate in Israel. And we are actually the largest one of 4, covering a little bit over half the population, which amounts to roughly 5 million people. We have clinics and hospitals throughout the country. And the very interesting thing about our system is that we've been digitizing our health records since the 90s. So right now we have about 20 years of medical records that we can use for improve the lives of our patients, derive insights, and apply better medicine using this research. It amounts to billions of records, and it encompasses many different clinical worlds that correlates to the services that Clalit provides to the patients. So we said that we have both clinics and hospitals, so we have everything that you can imagine that will be recorded in a clinician visits and a general practitioner visit or pediatrician visit, but also for the hospital visit. And also labs and medications, procedures. So it's really very, very large and rich and deep data set. So on top of the fact that we cover the care continuum, hospital and clinic, the system in Israel is so that not many people switch from one organization to another, one healthcare provider to another. So we have data for most people from their birth to the end of their lives. Another good thing about the Israeli system is that a lot of the services are free or very minimal out-of-pocket fees. So the data is very, very rich. And we have multiple data sources. At the same time, the EMRs are centralized. We have just one EMR for the clinics and one EMR for the hospitals, and then a few more for the labs and for the medications. But they're all collected to one data warehouse or a data lake that can be used for research. We do research at Clalit in 3 different ways. Our diamond in our crown is the Clalit Research Institute that provides a full service of the data research, both for internal purposes, as I said, using this data to improve our service and improve healthcare, and also in participation with partners, academic, and from industry. But we don't share data in this way. We share the results or the reports or the aggregated data, so to speak. We have this research institute for over 10 years. The other way is the data centers, which is a rather new network that was started about 2 years ago, and it's meant for internal researchers. It's meant to encourage the clinicians at Clalit to perform medical research by making the data available for them in an anonymized way. A third way that we are launching these days, very, very soon, is the cloud access for partners. So we will make this data available on the cloud, similarly to what we have for our internal users. We will make it available for external partners as well. I will briefly mention, touch upon each one of these ways. So I mentioned Clalit Research Institute, which really takes this data and takes it to the maximum, because it combines also a very professional set of researchers, epidemiologists, data scientists that really know how to perform the right kind of research on this data, apply the newest techniques and from data science to epidemiology. And it has a track record of success in, especially in recent years during the COVID pandemic. The Clalit Research Institute was able to provide very quick insight into the pandemic, into the effectiveness of the vaccines through retrospective research. It was able to help Israel and other places in the world to take measures and really make good decisions, informed decisions about how to manage the pandemic. And as I mentioned, we work in partnerships with academia and with pharma to improve, to research the many aspects of healthcare, diseases, etc. And we're also a partner for a center of excellence with the World Health Organization to research non-communicable diseases. The second way of research that I mentioned, the data centers intended for internal researchers in Clalit, is basically a copy of the data that we use for operational use in Clalit. It's an anonymized copy that constantly being uploaded for a separate secure network for research use. We have 8 local centers in the different districts throughout the country, which has teams that help support the researchers with the different aspects of performing this research. And there's a team at headquarters here in the office where I'm sitting right now that oversees all the professional and technical activity of data curation, of training and guidance to the researchers and setting up infrastructures, etc. And this way we hope to really encourage clinicians to perform more and more research, and we really see a lot more of activity, especially from clinicians in the community, and doctors that weren't able to do research before. So it really helps everybody all around. And for the cloud access, which is the third service that we are about to launch very soon. So we have set up a cloud service powered by a software that is dedicated for real-world data research called LinksMD. It works on AWS cloud, and it provides the access and subscription and all the tools needed allows uploading machines and do all the visualization and analysis tools to perform data research on the health record data research. We currently are in advanced proof of concept with 2 partners, and as I said, we're going to launch it very, very soon. We still have some challenges managing the scale of the data, having a lot of users at the same time, managing the big data in larger files like the video files, the images files, diacom files. They're harder to manage, so we still have these challenges. Other areas of consideration I can mention 2. One would be corporate focus and attention. So Clalit Health Services is an organization that was founded, and its goal is to provide healthcare. And research is always the second goal and not the first. And this is the way it should be, right? But this way, the secondary use for data always needs to be, persuaded. So we need to get decision makers inside our organization to provide the right resources for it, etc. And with the same context, there's the data security and privacy, like the people before the talk before me said. We do not want to risk any breach of data, and this is the highest priority. So everything we do when we share data is done very, very, very carefully and very securely, and we would not rush into any progress too quickly. So with that, I would like to thank you, and I would take questions later if you like, and invite you to connect with us and partner with us on research.
Thank you very much, Yael. So, Dr. Schneider, would you please take the floor?
Yes, thank you very much. I'll try to share my screen. As I said before, I'm having a little bit of technical issues today.
That's a fascination about Zoom sessions. We've all been there and all gone through.
Yeah, we're usually working with WebEx.
Oops.
I'll try it this way.
That looks like we are receiving some kind of...
What is it? I can't even see it.
It says it's transferring your screen, and you need to grant access for your screen.
Yeah, but it's not doing it. Try it another way. If it doesn't work, I just do it without the slides, and I just go.
Also fine.
Yeah, because I can't figure it out here.
If you'd like,
quite
we
a
can
shame, actually.
send around the presentation also to the participants afterwards, if you'd
Yes.
like. So
Yes.
that's also an opportunity.
Yes, because I just
or if it's
shame. No.
Yeah. Okay. So we just go ahead with that.
Yeah. I still have my slides on the other screen, so don't be, I'll look that way. Okay. So anyway, thank you very much for the invitation, and sorry for the technical problems. I'm very happy to be here today and to present the German Health Data Lab, the Forschungsdatenzentrum Gesundheit, which is an independent unit of the Federal Institute for Drugs and Medical Devices. First of all, the Health Data Lab provides existing data pursuing the following objectives. First of all, we're trying to be research-oriented, meaning that we're trying to facilitate access to health data, and to do so, we are closely collaborating with the data users. And then also a very important aspect, as already mentioned in the other presentations, is data security. And of course, it needs to be considered that the data that we're providing or will be providing, we are still in the setup phase of our infrastructures. We're not operational yet, but once we're operational, of course, it would be very important to keep the sensitivity of the health data in mind, and yes, to be sure that all security issues are addressed in an appropriate manner. We are closely collaborating with the information security and data protection authorities here in Germany. And then what is important to mention is that the purposes the data can be used for, they are restricted by law here in Germany. And one of the most important ones is surely just to improve the healthcare quality. And to do so, it is possible to use the data to form treatment regime analysis. It can be used for resource planning. It can be used for control tasks. The data can be used for healthcare development analysis and long-term longitudinal analysis. It's quite a shame we can't see the picture here. That's quite a nice one, but okay. Then what types of data do we have? We will have data from all kinds of medical sectors. We'll have inpatient and outpatient data, personal information about the patients. We'll have drug prescription data, also drug dispensing data, other kinds of data like aids and remedies, midwife care, digital health applications, and in the future we'll also have data from the electronic health records. I'm going to talk about that later. And that would be data from all 72 million people with statutory health insurance in Germany. So quite a lot of data. And all the data from the different health sectors will be linked on an individual level. The data are starting from year 2009. And well, we have the established coding systems such as ICD-10 and ATC coding systems. But the health claims data is something very important task that still needs to be done is to convert them to a common data model. Regarding the electronic patient records, that will be a little differently. They will be voluntarily shared, meaning that the patient, they can give their informed consent to share the data. And we are planning to start that in year 2023 with the structured medical information objects. Professor Thun has already mentioned the so-called MEOs, and these one will actually be in an HL7 file format. We're starting with the e-certificate of vaccination, the e-dental bonus booklet, the e-maternity record, and the e-child examination booklet. Those will be the first MEOs we're starting with, but it is planned for the future that this will be extended to laboratory test results, for instance, or medical imaging, for instance. And then very important topic that needs to be mentioned is that also the data users that can apply for our data are also restricted by law. So that can be healthcare provider organizations, it can be patient organizations, the health insurance sector, research institutions and university, public institutions such as HDAs, for instance, and national agencies. But for instance, the private sector is not included. And then a little bit about the data provisioning process. So what is planned once we're operational is that the user chooses the required data in the electronic application form. The Health Data Lab provides anonymized test data in a secure processing environment. The data user develops an analysis script based on these test data. The script is being run on the original data by the Health Data Lab, And the aggregated results are being evaluated regarding the re-identification potential, and then finally the Health Data Lab provides the aggregated results to be published by the researchers. So I would really like to show you the screen now, because I just wanted to give a short hint to our homepage, which I can't show you now, but you're very welcome to just search it on the internet. It's currently only available in German, but we're working on the translation, and I think it'll be available in English soon. And then what is planned is that the application process will start from this homepage. So you need to register first, and then you can start the application process. And yes, I brought some screenshots, which I can't show now, but yes, I think considering this, I'll just go over to the projects that we're currently performing or planning. The first one I want to present is a national project. It's about synthetic data and AI readiness. It's a project that is funded by the Federal Ministry of Health. The aims are to create synthetic data with AI methods and then compare them with classically anonymized data. So we have these two parts, and in the end, we're trying to compare them. And then afterwards, we're trying to evaluate the AI readiness of these data. So can you actually perform analysis with AI methods on these data? And the last pillar of the project is the European connectivity. I'm going to talk about that later too, especially with regard to AI methods. The project started in November 2021, and it'll go until 2024, end of 2024. And we have 3 partners working with us: the Institute for Applied Health Research in Berlin, the Berlin Institute of Health at the Charité, which is Prof. Brasser, and the Fraunhofer Institute for Digital Medicine. And who's interested in the project, we've just recently written a blog article and published it on the BfArM homepage. So if you're interested, you're very welcome to visit that. And then last but not least, I would also like to give you a very brief overview of the international initiatives we are participating in, which is on one hand initiatives towards the European health data space, which is the TEDAS joint action. We're actively involved in that one, and we've submitted a grant application to the EU Commission in January for the EHDS2 pilot project. So those 2 projects are heading towards the European health data space. And of course, we're very actively engaged in any EMEA projects heading towards, use of big data and secondary use of health data for regulatory purposes. For instance, the head of the Health Data Lab, Dr. Stefan Hess, he can't be here today. Sorry, he's a member of the Big Data Steering Group. I am a member of the Darwin EU Advisory Board, and we're also actively involved in the National Initiatives Network. And all these kinds of projects are actually also highly interconnected. So it's actually a great pleasure to work with all these interesting people and all these initiatives, and to bring forward all those European ideas and yes, perspectives. So yes,
thank you very much.
Thank you very much.
Yeah, Dr. Schneider, and I'm sure we can send your slides to those who have been registered for today's event. If you would like to forward them to us, so we'll make sure they will be seen. So that brings us already to our last impulse topic for today, which is about the evolution of healthcare through data linkage. And it's my pleasure to announce that we will have Rina Shainski with us, the co-founder and chairwoman of Duality, a provider of privacy-enhancing technologies, and Dr. Gadi Lalazar, who is the chief medical officer at Bryia and director of hepatology at the Charité Medical Center. So, Rina, would you like to take the floor first?
Yes, thank you very much. And I will also share my presentation. I hope you can see it. So I will be indeed talking about how to use technology in order to enable collaboration in healthcare. Just a bit of a background on the evolution of data and use of data. So the first challenges are really around collecting the data, and everybody were mentioning it from various directions, then applying analysis to it. Then it evolved into training models and applying machine learning models. And now we are really reaching the time of collaboration on data, because everybody realized that to extract maximum value from data, we have to collaborate, especially in the healthcare field, where not always each organization has enough data or the sufficient type of data. And actually, you see this progression, but it doesn't mean that every phase was finalized before the next phase has arrived. So we are still having challenges with collecting data, as was mentioned. We need to have common language. We need to have the words to mean the same thing. So that's why FHIR and that's why ICD. But we can make a lot of progress already with what we have. And that's basically how data science and data enterprise are progressing. So specifically in healthcare, to be a data-driven healthcare ecosystem, it's very important to be able to enrich the data, to analyze the data, and as we all said, collaborate on data, and also to use all these wonderful resources of cloud computing. But to do this, the modern data-driven enterprise has to be data responsible. And we also all mentioned, and it was mentioned from different directions by the speakers, so we have the tools of data science. They are great tools. They work. We have good confidence in them. We know we have to collaborate, but we also have to be responsible and to make sure we deal with data privacy, with confidentiality and security. And that actually gives rise to a new set of tools called privacy enhancing technologies. And this is maybe the first very important message for me to this forum, that technologies already exist to enable privacy enhanced collaborations. And this is actually a basket of technologies, and some were mentioned already, such as synthetic data, encryption in use, so protecting data while using it, trusted execution environments, differential privacy, and federated learning. These are the key ones, and you may have heard these buzzwords already. Important message, these technologies are already ready to be used, and I will show you some proof how they are being used. And the difference will be how you want to collaborate, what is the purpose of collaboration, how precise you want to be, how accurate you want to be on your results. Do you want to use the results, for example, to predict risk on patients versus providing data to others to basically just get a sense of how healthcare data looks like? So there are definitely differences in purposes, and the tools address different use cases. So there is so much value to extract from data collaborations in healthcare. I believe we all agree about this, and it was mentioned, and this is around precision medicine, around real-world evidence, decentralized clinical trials, etc. So many examples of how collaboration on data is important in healthcare. And even though the data in healthcare, as was mentioned, emerged as secondary use of data, but it's now coming to the front because this is the only way for everybody to deliver evidence-based results. So what Duality offers is really this platform that makes it possible to collaborate on sensitive data without exposing it. And it delivers at the same time security, privacy, and utility. So just will give you quickly a few examples. We performed a study with the oncology department in Tel Aviv Medical Center, showing that it is absolutely feasible today to perform an analytics on encrypted data without decrypting it. And this unlocks the possibility for collaborating on very sensitive data while absolutely guaranteeing to patients that their data will not be disclosed, even if it's difficult to get a consent, because in oncology, sometimes the people are not available anymore, but their valuable data exists and can be learned from. And this technology makes it 100% guaranteed that organizations can collaborate on sensitive data without disclosing the actual individual data elements. Another study that was published in the Proceedings of National Academy of Science is that it is possible to collaborate and to do analytics even on very sensitive genomic data, genomic variance data, and to do studies such as GWAS on encrypted variants, and to do it at scale with good performance. So coming back to the linking question, this privacy-enhancing technologies makes it possible for organizations to collaborate in order to achieve either critical mass of patients' data. Like in oncology, we know it's very challenging because it becomes precision medicine. No single medical center has sufficient number of patients, but together we can do very meaningful research. And with these privacy-enhancing technologies, it's entirely feasible today to build data sets which are protected by technology and to derive very valuable insights from these data sets. Another example, when you have patients in two organizations and each organization has complementary type of data, it is possible to basically privacy preserving record linking that was mentioned in the paper, it is feasible today to do without disclosing the patient's identity, and then to compute some statistical analysis on the intersection, which means on the same patients, combine their data values without disclosing who these patients are. And that gives an example that I heard from medical professionals, that one organization has, for example, genomic variants, while another organization has immunotherapy response. It is possible to combine to see the same patients and to correlate the immunotherapy response with the genomic variants without disclosing the patient's identity. So all this technology already exists, and that's very important to realize. So if you think about collaboration projects and you would like to discuss how is it feasible to do without disclosing sensitive information, it is very happy to address this and to answer more detailed questions offline. So this brings my talk to conclusion, and thank you very much.
Thank you very much, Rina. And last but not least, we have Dr. Gadi Lalazar. Please, Gadi, the floor is yours.
Thank you so much. I'll just share my screen. It's great to speak after Rina. And I'm very excited to be here. Can everybody see my screen? Great.
Yep, it works.
Okay, great. So I'm the Chief Medical Officer at Bryia, and I'm also the chief of hepatology at Charité Medical Center in Jerusalem. So a gastroenterologist, hepatologist, that's what I call my day job. So I'm excited to share with you today our vision to some of the problems that we've discussed today, and also show some of the solutions that we've been thinking about to the many problems that have been brought up in this wonderful session. So the way we look at it, as many of you have already mentioned, is that what we're looking for are longitudinal, complete patient healthcare records. And the reason that this is one of the holy grails in medicine is that we have a premise that the more we know about a patient, the better care we can deliver, and also the more efficient and relevant our research is. But this understanding of what a complete healthcare record is really a understanding in progress. And, we talk about patients getting their care in different centers, but really it's much more than that. And data linkage can also speak about completely even non-medical data that we might want to integrate, such as education, performance, and wearable data as well. And the way to connect all of this to meaningful records for better care and for better research is data linkage. So the challenges, which I think this forum is very well versed on, are that usually the data is disconnected. It's found in different and non-compatible formats. And even within the same organizations, it's often siloed. Especially within pharma, there's a problem where different branches of the same company might have siloed data, and it's very hard to connect that data together. And also we're dealing with healthcare data, so there's an added layer of sensitivity, obviously. Now, patients get their care in different locations, and their data is stored in different places, often in non-compatible formats, and that's what poses the challenge for us. So some of the way that this has been approached is via registries, and the way to follow a patient and to collect data that is beyond the record that can be found at any single institution is to bring those patients in and to manually collect that data, thereby doing some double work. And also, a lot of this is based on questionnaires and recall, and it doesn't necessarily reflect the real world. And one of the revolutions we've been seeing during the last few years is the entrance of real world data. And this has really come up from the field and has even prompted the FDA to address this with guidance of how to use this. And we have some fascinating use cases of how this can be used to bridge regulatory gaps that would otherwise not happen through the usual clinical interventional research. An example that's close to my heart is a drug called terlipressin, for example, which is used for patients with liver cirrhosis. And amazingly enough, this drug never made it to the US because the company didn't have enough time left on its patent, and it wasn't worthwhile to redo the study on US patients. So arguably one of the most advanced countries healthcare-wise does not have a drug that everybody else, especially in Europe and Israel, uses, and it's quite amazing. And that's the way it stayed. Now, some of the use cases, for example, talk about population bridging, where you can now use real-world evidence for a drug to bridge from a clinical trial using this real-world evidence, leading to regulatory approval of a drug and label expansion without having to repeat a clinical trial. So these are some of the exciting use cases that are now coming in for real-world data. Now, when we look at real-world data, the challenge just becomes even more real, because it's not only are we looking at different locations where the data is stored, there's the issue of data harmonization. Different speakers have spoken about the use of FHIR. There is the problem of timescale, data quality, compliance and privacy, and data anonymization. So let me speak about each of these and how we approach it. So one of the things that is, to my mind, most important is also the timescale that this can be done. And one of the things that's exciting at Bryia is that the integration time for each of these sources is quite short. And the reason that is that usually the solutions require pre-indexing of data. You have to, in fact, go through many months where you have to work through the data and rearrange it in order to make it searchable and to harmonize it. Here, the ability to work with a general data scheme allows this to be done within a matter of a few weeks. So no pre-indexing is required. the way this is changing these projects is that now, instead of working with a company that is already integrated at a center, you can have a project in hand, you can identify the healthcare center, for example, or the registry that has the real world data that you're interested in. And then within the time frame of the project, you can integrate into that healthcare system and have use of the data. The connector will then harmonize translate the information into FHIR format, therefore making it possible to harmonize the data between different sources. The fact that this is done using inquiry time search, in essence, means that we never actually take the data out of the center. We don't also have to warehouse it separately. The connection is into the EMR of the healthcare center, and the search is then done on the EMR. And this means that the data you get every time is the most up-to-date data because it is exactly reflecting the EMR, barring the few hours that or minutes to hours rather than that the query takes. One of the challenges that we in the field face is obviously the work of structured versus unstructured data. So natural language, a lot of the physicians' notes are in natural language, some still in handwriting are a challenge. So this is, I think, something that we have to tackle as a field. A lot of the information that we are interested in for the completeness of the healthcare record is still unstructured. And this, I think, through intelligent partnerships is something that we can definitely solve. Then we get to the issue that several of the speakers have been talking about, is compliance and privacy. So one of the issues that we have incorporated is the fact that even if the regulation is there and the compliance is there, you have the agreement and the data is compliant, there is nothing necessarily that is preventing human error within this process. There's always place for human error. One of the things that we've incorporated is something called smart contracts, and this does auto enforcement of this regulatory compliance, be it HIPAA or GDPR. And what that means is that it goes through a type of gate that even if this was approved by both institutions, if there was a human error, let's say a non-malicious human error, the auto enforcement mechanism will not allow non-compliant data to exit to the data user. Finally, we spoke about data anonymization. So this is really interesting because, first of all, in many places it's still done manually. The solution here incorporates automatic data anonymization. But there is also another aspect of it, may be really important for example, genomic data, where you have active prevention of re-identification, where the system will then track the attempts to re-identify data via different queries that are trying to cut the data different ways in a malicious attempt to re-identify. So in the different layers that we discussed regarding security and privacy, this is another layer of protection that we think will really improve our ability to anonymize and remain compliant with the data. That's it for me. I as well would like to invite anyone who is interested in exploring projects with us to reach out, and I'm happy to take any questions. Thank you.
Thank you very much for this overview, Gadi. And with this last presentation, we have covered all the topics on our agenda. We're a little bit over time already, but nonetheless, let's see. Leah, do we have questions from the chat?
Yes, we do. Thank you also from my side for all the very interesting and fruitful talks. I'm going to start with one question posed by, one second, Harald Schmidt. We are doing big data research now and on hundreds of thousands or millions of patients' data from UK, Denmark, Finland, Estonia. To me, a lot of these discussions sound like we need to invent the wheel while others are driving around in four-wheel drives already. Why not learn from these countries and just copy their approach? They have perfect longitudinal databases and biobanks. I think perfect question for this talk, because this is also what the program is about, right? To learn from other countries like Israel.
Wonderful. Anyone who would like to pick up this question?
I'll maybe take a stab at this, if I might. I think one of the questions is, even if you have longitudinal records, the question is who has access to them. So if one institution has longitudinal records that are held at an institution and a researcher would now like to have a multi-center trial, then that's, of course, a challenge of first challenge is how this researcher can identify these patients at all. I think Rina spoke about this, the precision medicine. How do we find the patients with the exact genomic lesion that we're looking for our precision medicine basket trial? Now, if these countries have figured it out so everyone has access to everyone's longitudinal data, then I totally agree. But I think usually the case is that you still have research that's needs to be done. And access has to be somehow provided to researchers who are asking the question, academic or pharmaceutical, both alike.
Yeah, I just will add that the fact that repositories exist is not necessarily solving all the problems of collaboration. So there are repositories, very often very difficult to access depending for what is your goal. And some of the collaborative research wants to work on a specific condition, specific treatment. And this needs to be not necessarily something that already sits in some repository. So it's really a question of, A, do you have, whether the repository has all the information that you need? B, do you have access to it? If it's sufficient, then you don't need to do anything else. But very often that's not the case.
Thank you very much. I hope that answered the question. It's a very long and complex question. So the second one is by Pretty Amarish. In the era of biowarfare that the world has experienced during COVID, can countries like Israel, Germany, US, etc., help to bring in new AI technologies in health to keeping in mind the advanced healthcare in these countries?
Again, the question to the whole panel. Who would like to pick this up?
Maybe I can try. I'm yes, actually not sure. I'm going to be brave and say that I'm not sure that I fully understand the question, and perhaps invite the participant to join us and help us understand the question better first.
Let's see. Is the Leah?
Yeah, sorry. She's Pretty.
Who was the question? Is she still with us?
I think I still saw her. Mrs. Amaresh, if you want to raise your voice.
Yeah, can you hear me?
Yeah, perfect. Yes. And see you.
Yeah, so like they say that, China has, done the biowarfare. So like in that case, in the future, if something like that happens, would countries like Israel and US and most of the advanced European countries who are good in healthcare research, would they find a solution for this kind of, biowarfare, new kind of viruses in healthcare? I mean, like vaccine. Yeah, that type.
I think that definitely for Israel, at least from 2019, the government's policy, declared policy by government decision and acts and budget, is to have Israel be a leader in both healthcare, digital health, and AI development, and also participate in collaborations with other countries internationally. And these projects include creating data lakes or creating regulations or interfaces or virtual clouds that allow for access to data for the purposes of research also to researchers or private entities or academia from other countries in order to collaborate. And the whole concept of what's Israel's government, Ministry of Health, is trying to promote is to create the infrastructures, both technologically and legally and policy-wise, to create these types of international collaborations around R&D in the digital health sector. So I think that's the future, and I think that's something that is absolutely crucial to be done, and this forum is part of trying to build that bridge.
Thank you very much.
Thank you very much. My next question is to Dr. Katharina Schneider. From Mr. Jens Wieler, why does legislation not allow the industry to access FDZ health data, and when do you expect this to be changed?
Okay, why that is? That is a question I'm not sure I'm the one to be able to answer, because it's not us who actually, make the law. I think I can say something about the second question, maybe, because what is currently being a very important topic is the creation of the European Health Data Space. And I'm pretty sure that this is going to affect our national position as well. And we don't know what it will look like, but of course, this may have in some way the possibility to work on this, but we don't know yet. So I think it's a question I'd like to postpone a little bit and see what the future brings. But yes, the fact is that the current German legislation just doesn't allow for private companies to apply for the data.
Limor?
Thank you.
Maybe just to supplement on the EU Commission level, the policy allows for the legislation of national laws, member state laws in each country of the European Union that allow for this secondary use of health data for research on a national level, so from health organizations or entities that are of the government. And this has been done in England, in Finland, and I think that, from what I know from the data protection and privacy community, Germany has internalized privacy principles in a more rigorous way in comparison to other member states of the European Union, and it's the prerogative of each parliament and each member state. But I absolutely agree that the creation of the health data space in Europe is maybe potentially going to drive all member states of the Union to maybe collaborate more on data. I would point out, though, that the health data space is meant to pull together only European data. It's not an international type of venture. So thinking about the previous question and the potential, and I think also COVID showed us that pulling data from more continents, more jurisdictions, more countries, more populations, I think that having data sets that are only European-centric would give us less diversity in the data. So for research purposes, we might benefit from inclusion of more populations in hubs of data, of health data for research.
Right, wonderful. I see that Nick Schneider from the Ministry of Health raised his hand.
Yes, hello everyone. Thank you so much about your very concrete and clear messages. I just wanted to briefly touch upon the issue of different interpretation of the GDPR within Germany. And I think one thing we have to consider when talking about data protection in Germany is that we are in a bit of a sandwich situation when it comes to the national competences, because we do have the GDPR on top that on national grounds from a historic perspective, coming from the 70s, data protection is being governed on state level. So we do have state law which takes precedence over national law, and we do. You're totally right, Limor, that we can, on legal grounds, on the GDPR, allow certain things, but we are dependent on the state legislature here. And what comes on top is that we do have, in total, 18 different data protection authorities, 17 on state level, Bavaria having 2, not only 1, and 1 on federal level. And I think that shows the complexity we have, because they are allowed to interpret the data protection law from state, federal, and European level differently. And I think that makes it so very complicated in Germany. But I think that's why I see in the area of secondary health data use the huge opportunity we have now with the European health data space. Because if we manage to have a clear mandate for health data use on European level, that would take precedence over the state legislature, because it's European law. So we would actually solve those problems we have on national level by bringing them one level higher on the European agenda. I think that's something, it solves European issues, but also national issues. I think that's something which we need to always bear in mind with the upcoming negotiations, which we're going to see in the upcoming 2 or 3 years. And I hope that Israel will also help us there and really establish this strong European health data space, because I do think that it will also have a positive effect on the transfer of data and collaboration between Europe and Israel.
Very well. Thank you very much, Nick, for this intervention and clarification. And looking at the time, unfortunately, we run out of it and already extended your commitment here. So I'm afraid I have to stop this session for now, the roundtable, and to conclude. So again, thank you very much to all of you who joined us for this very first roundtable of the German-Israeli Health Forum for Artificial Intelligence. It won't be the last for sure. We just initiated and kicked off this work stream. The experts will continue to discuss on several issues and questions raised during the presentations and afterwards in the Q&A session. Please have a look at our website of the GIHF-AI program, and you can find there already a first brief policy paper that is a good further introduction on this topic. In a short while, you will also find a brief report on today's session and recommendations for policymakers and industry experts, touching on everything that we discussed so far. So again, thank you very much for joining us today. I'd like to invite the experts now for the workshop session. We'll do a 5 minutes break, and you have the other link, so to switch to the room. And for everyone else who was with us today, thanks again, and hope to see you soon.
Thank you very much.
Thank you.